And there's one more which actually showed that 4.9 and 21% difference in the leak rates. But I don't know how many actually practice this. And making a gastric tube, you should be very careful. Most of the times it is done with a linear stapler. And again, the width of the gastric tube is very important. It's ideal to have not a big tube or a small tube. It's actually the 4 to 5 centimeters is the ideal conduit that you have it. And even though there are many studies which have looked at the making of taking the whole stomach and making a tube and all that, they have seen many studies have been done, which they try to see if there is any improved blood supply or gastric emptying by doing that. But there are not much differences, not much difference. I mean, it's the ideal one is still what we make as the 4 to 5 centimeters conduit. And the pyloric sphincter is one area where many people do like differently. That is because it's denervated, they say it can actually lead to the gastric emptying problems. And so there are many techniques that are followed, but that's just pyloromyotomy or toxin injection or pyloroplasty. But again, this need for these pyloric procedures, drainage procedures again is questioned because there are some meta-analyses before that. And they have not shown much benefit of all this on gastric function. Actually, they do not support its routine use. And anastomosis, we have a lot of techniques. The site is again chest or neck based on what surgery you do. And techniques hand-sewn, mechanical staplers and combined. The hand-sewn is one which if you're doing in the neck, you can do a hand-sewn one. This is basically you select an area where there is a good vascularity on the stomach and anterior part, and then open and do the posterior layer and then anterior layer, and any redundant part you can excise that. And using a stapler, we have many techniques. One is the Oringer one, that is a side-to-side linear stapler. So you just posteriorly you take a sutures and then put one linear stapler about 3 centimeters distance, and then anteriorly you just close it. You get a big anastomosis with a V-shaped thing that you get. And then we have something like a collared anastomosis where we actually fire a stapler, again linear stapler across, and then second stapler is fired like this. It's more of a side to side. And then we have a triangular anastomosis, again where the 3 staplers are used. This actually makes a bigger lumen. The initially one posteriorly, and then the anterior one is used like a triangle. 2 staplers are used. And then you can use even a circular stapler for this. And there are a lot of studies which have compared everything, but there's one study, actually this one, which has shown that the leak rates are little more with the circular stapler when compared to the other ones. Otherwise, long-term risk. Then intrathoracic anastomosis, again, it's the same thing. They have shown like better to have a higher up in the thorax than in the middle of the thorax. And we have circular or linear staplers. And some people actually make the gastric tube inside the stomach and then bring it up, or sometimes they bring it into the thorax and then do the anastomosis and then resect the part. So both the ways it is done. This is, you have seen the videos how it is done. Of course, the complication reflux and gastric emptying. Going to the colonic conduit, when you don't have stomach, then the second option is the colonic one. Again, it's a versatile one. You can take any length of the colon, but you have to make sure good vascularity. There's a variable anatomy. The most one, what we prefer is the one which is the middle one, that is which is dependent on the ascending branch of the left colic artery. That is the one which is ideal. And but most of the times you may not have planned. If you have planned preoperatively, you can do colonoscopy and angiography just to make sure, and then prepare the thing and then take it up. But anastomosis is almost same. In the stomach, we actually do the anastomosis close to the greater curvature on the posterior aspect of the stomach. And sometimes we can even supercharge. The outcomes, actually, the incidence of necrosis is slightly higher with colon when compared to the stomach. And with that, actually, a little more leak rates are there. But another problem with the redundancy over the long time, especially when you do the substernal route, and you can have a reflection disc colitis. Jejunal one, there are 3 types you can use: Roux-en-Y loop, and then interposition. These 2 you can do if there's short segment, and then free vascular graft that is done. But it's again a difficult procedure where you need to do a microvascular anastomosis. But otherwise, this is supposed to be a good one. So the first choice is obviously the gastric pull-up. And if the gastric conduit is not available, I mean, ideally it is the jejunal interposition, but again, it depends available the technical expertise, because jejunal one is the ideal one if not available. But yeah, go for the colon, okay. And the roots, as I said, there's not much of controversy. It's usually the native root that is used. If you don't have that root because of any issue, then you use the substernal or subcutaneous. Thank you very much.